So after failure, let's say, for example, a patient gets 6 cycles of MVAC or Gem-Cis and progresses after he fails, what would you then do?
Yeah. So this is obviously a unclear data zone. There is no clear standard of care in the United States in regards to second, third line therapy and beyond. In Europe, there was a randomized controlled trial using vinflunine, which is a type of taxane, and they did, in a multivariable analysis, were able to show a survival benefit. And so vinflunine is available in some places in Europe. So that's a reasonable standard of care to use there. But in the United States, we don't have that option. So what do we reach for? Well, most of the studies are small phase 2 trials where the response rates vary anywhere between the 10–15% range and as high as maybe even 25% or so. But we reach for taxanes. Taxanes can be used in this setting. Pemetrexed also has a reasonable track record and activity in this disease as well. And how we choose that oftentimes depends upon patient comorbidities. Pemetrexed, you have to look at renal function, and you have to be more concerned about somebody that has significant renal dysfunction. Whereas with taxanes, you can treat somebody that's more renally compromised, but certainly you have to look at hepatic function as well. So if you have somebody with many hepatic metastases and the transaminases are sky high, probably not the first place I would go. So I think those are reasonable standard of care chemotherapy regimens, but the real excitement right now is the fact that there are a lot of clinical trials that are ongoing for this disease state.
Exactly. Well, the neuropathy also is an important issue with the taxanes as well, and that has to be, particularly if they've had cisplatin previously, that has to be looked at carefully. Dean, do you have a preferred regimen that you use in these patients?
Well, not a regimen.
Well, actually, preferred single agent.
Single agent. And so I think a couple observations. One is not all patients who are presenting with previously treated disease are the same. Again, there's heterogeneity in that patient population. We might have nodal-only disease versus the patient you're talking about, Evan, that has extensive liver metastasis and low hemoglobin. Those patients do particularly poorly. All of us have had experience in doing studies in this setting and trying to develop new drugs. And I think collectively what we're seeing is that if we look at all the studies that have been previously published, the median progression-free survival is about 2.5 months. And so even though there's heterogeneity and some patients do a little bit better, as a group, they do extremely poorly, and their disease is really marching on quite quickly. We will typically follow the NCCN guidelines. That includes the taxanes, it includes pemetrexed, but even pemetrexed, for example, giving it under, with a creatinine clearance less than 45, it's really unwieldy at that point. So I guess the word I'll use, you have to take caution there. So we really need something that one has activity, two has durable activity, 3 is well tolerated in this patient population that might have been frail to begin with, and then we treated them with first-line chemotherapy or second-line chemotherapy. And so I think, again, it's asking for new drugs.
Exactly.
We don't have a single FDA-approved drug in this setting.
The interesting thing about this disease, and we do see some outliers. There's some people who relapse a year or 2 years afterwards. In fact, I think one of the greater red herrings about dose intensity was Chris Logothetis' MVAC, or escalated MVAC trial, where when you looked at those patients who responded to increasing the dose of MVAC, the time from their initial chemotherapy treatment was generally about 18 to 24 months. So you do see some patients who may respond to their original induction regimen, but those are generally people later on in the course, and again, they're probably biologically very, very different. What about a patient who relapses after neoadjuvant chemotherapy, let's say 6 months afterwards? Would you consider that patient to be a second-line patient, or would you try a first-line regimen?
So I think that the general tenet of what we're all seeing here is that a relapse or progression of disease within 12 months is generally disease that is probably going to be refractory to similar cisplatin-based therapy again. And so we wouldn't consider that patient. We would consider that patient a second-line candidate, not somebody to be retreated with the same therapy. I think between 1 and 2 years it gets a little foggy, but I think that most of us are, as our legal colleagues would say, choose a capricious and arbitrary point of about a year or so as therapy that might still be sensitive to a platinum-based combination again, but before that, or shorter intervals, really don't do well at all.
Exactly. Evan?
I have the same approach. And it depends in clinical trials. If you look at the eligibility, most clinical trials will state that if you received perioperative platinum-based chemotherapy and you relapse within either 6 months or 12 months, depending upon the trial, then you'd be eligible for that second-line trial. And again, I feel the same way. Certainly, if it's less than 6 months, I move on to a different class of agents because that's platinum refractory disease. If it's greater than that, greater than a year, then certainly I would probably re-challenge. And if it's between 6 to 12 months, I think that's a hazy zone.